I'd like to invite our first speaker, who's Dr. Gina Ogilvie. She is the Director of Clinical Preventive Services at the BC Cancer Agency in Canada. So welcome, Gina.
Thanks very much. Good afternoon. It's lovely to be here. This is my disclosure slide. So today, actually, I'm going to just, first, I want to just draw to your attention in the vaccine supplement that was given to everyone in their registration packages is a great review by Phil Castle and his team about the state of HPV-based cervical cancer screening around the world. So I just want to draw your attention to that document. What I'm going to do today is just to very briefly highlight what's happening in Europe and happening in the US, because certainly the US has probably been at the forefront in terms of using HPV as part of cervical cancer screening. And then I'm going to talk a bit about Canada and how our federation has tried to move forward and where we are and what some lessons are for us as providers and what some lessons are for us as we consider deployment of HPV-based cervical cancer screening. So certainly in Europe, cervical cytology remains a standard of care for cervical cancer screening. However, Europe is certainly one of the leaders in terms of implementation of very large and very relevant RCTs, providing the foundation for HPV-based screening. The Netherlands has a very comprehensive report out, and they are planning to switch to HPV-based primary screening in 2013, according to their website. In Italy, HPV is listed as an alternative to cytology for women older than 30, but it's unclear how widely uptaken that is. In Sweden, with the Karolinska Institute, there is a large pilot study going on with HPV-based primary screening. And in the UK, although it's not routine, HPV-based screening is under consideration. So those are some of the status highlights from Europe. When we look at the United States, in 2003, recommendations came forward for co-testing with women who are older than 30. And I think what's impressive to me is that you have relatively, and I'll show you a slide that my colleague Mona Surya shared with me, you have relatively now coherent and shared guidelines around HPV co-testing. So you have the Cancer Society, ACOG, and even now the U.S. Task Force on Preventive Health, all saying the same thing. I think many of us were hoping, and we'll chat a bit about it, that the U.S. Task Force would have gone a bit further in their results, but we can reflect on those. So you can see that the cervical cancer screening guidelines in the U.S. have a shared start time, use of cytology every 3 years for women aged 21 to 29, and then moving to co-testing for women older than 30. The U.S. Task Force does allow PAPs after the age of 30, but also has accepted co-testing every 5 years. And then with the recommendations for discontinuing as well. The U.S. Task Force, when they came out with the review this year about LBC and about primary screening for cervical cancer, they weren't ready to endorse primary HPV screening. They did agree that HPV testing was indeed more sensitive than cytology, but they were concerned about the trade-off for specificity. They felt it was very promising, but had substantial concerns about false positive HPV testing and subsequent increases in colposcopy rates, and also potentially interventions related to that. So they articulated that they were awaiting further data from pooled European trials and also from results of studies such as HPV Focal. I think one of the important things for us to take from the U.S. is to look at the very careful reviews that several of our colleagues have done, looking at how those guidelines have been adhered to or not. And we have some of those folks in the audience here today. Some very comprehensive evaluations, particularly from the provider perspective. As a Canadian, it's very interesting for me to see, because many times the way that we get, or I shouldn't say get, we facilitate guideline adoption is the system puts structures around us. And I think what's interesting when we look at the U.S. experience and you look at the HMO Kaiser Permanente, there's some interesting parallels for our Canadian system. But when you look at some of the broader practices, Mona and her colleagues looked at the adoption of HPV co-testing in the U.S. by surveying U.S. practitioners. And what was very interesting and concerning was that few primary care physicians actually followed the appropriate screening intervals for co-testing. We all know one of the benefits of co-testing is the ability to extend out the screening interval, but few primary care physicians were able to do that. And also, most practitioners defaulted to the screening recommendations that were for PAPs instead of for co-testing. There was also quite a significant difference depending on what the provider training was. And with that, in that study, it was found that physicians trained in family medicine and internal medicine had the greatest discomfort in extending out the screening intervals. They also found that use of liquid-based cytology was associated with a lower likelihood of extending the screening interval. In another study by Lee et al., there was a reporting of overscreening both with the HPV and PAP tests annually, and also inappropriate use of co-testing in women under the age of 30, and use of low-risk HPV testing, which most of us would agree would have no added value in terms of cervical cancer screening, by over 50% of practitioners. I think in contrast, when you look at the Kaiser Permanente group who introduced HPV co-testing, they were actually able to have very good adherence to recommendations, with over 91% of the women over 30 who had negative cytology and negative HPDNA actually having a screening interval that was quite appropriate of almost 3 years. So I think that when we look at lessons for adoption and governance and leadership, it's really important to start with not just the science and the clinical science. You need the guidelines of respected groups, but then you also need the system structures to support practitioners in what can be challenging decisions, particularly in the area of screening, where we always as clinicians tend to feel that more is better. And sometimes, particularly in the case of HPV, we need to be very mindful that more is not better, and we need to be very adherent to the screening intervals. In Canada, under the Constitution Act of 1981, healthcare is a provincial jurisdiction. And that's why whenever you see any slides of Canada, you'll see our provincial programs. Although there's a thematic sort of element that you can certainly pull out, usually there's some distinction because healthcare is up to the provinces, and the national government can make guidelines, but it's really up to the provinces to decide what to do, what to pay for, and how to implement them. But what national consensus conferences do is they help provide guidance and frameworks for the provinces for clinical recommendations. But like I said, you will very often, actually more often than not, see differences in the provinces in what they do. I want to thank Mark Steben for this slide, which shows you the current PAP screening guidelines. It's very small, the font is small, but I think what you should take away from this is that there's variation in terms of whether or not each province has an organized program. All use cytology, and some use liquid-based, and some, like my home province, still uses conventional. There's moving agreement to the age of 21 as the start, and the intervals are starting to coalesce together basically every 2 to 3 years, and then some variation of the cessation between about 65 and 70. So that's kind of a metaphor for how Canada is for actually most screening and treatment guidelines. For us to get to the place of HPV, a recommendation for HPV screening, we started with a workshop, a national workshop that looked at a report on national screening, pulling together leads from a very important multidisciplinary group of not only public health folks, but also family physicians, gyne-oncs, gynecologists, infectious disease, folks who had a broad range of interest. And that moved forward to a very important pan-Canadian forum that made some guidelines, not about what the guidelines should be, but about how we should go about moving forward towards HPV testing. And I think one of the key messages that I think many of us are proud that we were able to do is number 11 here, which actually says evaluation of HPV testing within a Canadian organized screening program. And that led to the genesis of the HPV focal trial in British Columbia. So these were some of the recommendations that we were put forward as a national group to challenge ourselves to move forward. Then we had an important document from the Journal of Obstetrics and Gynecologists, which is the journal for the Society of Obstetricians and Gynecologists of Canada, that made some very strong, clear statements about the role of HPV and HPV DNA testing in terms of cervical cancer prevention. We then had our colleagues in Quebec prepare and publish the CKS Trial, providing very important data on the efficacy of HPV DNA testing in cervical cancer screening. So you can see what we're building. We have a consensus group. We have recommendations from key opinion leaders starting to generate Canadian local relevant evidence. And then this is the objectives of the HPV focal trial, which is another large randomized trial comparing pap smears and HPV testing as a primary screen for cervical cancer. And this study is ongoing in British Columbia. So, and coming together under all of this is under the Canadian Partnership Against Cancer, that is a strategic initiative to look at cervical cancer screening as well as other screening. And so this provides the ongoing forum at a national level to look at screening. And I think as we look at, in Canada, where we're at with recommendations is we're moving forward. So the Canadian Task Force on Preventive Healthcare has pending recommendations for cervical cancer screening. The British Columbia Cancer Agency has pending recommendations that are based on results from HPV focal, but I think you'll find that they're very aligned with the Ontario recommendations. And Ontario, as many of you know, is the largest province in Canada, population-wise. And they have published recommendations in 2011, and they are recommending primary HPV testing for cervical cancer. It's recommended to start at the age of 30 and to end at the age 65, 5-year intervals, and they recommend reflex cytology. The sort of hook there, though, is that primary HPV screening can start when public funding is available. And so in Canada, because health is a publicly funded entity, you need to ensure that your Ministry of Health is on board in terms of providing the funding for it. And so until such time, the province continues on with cytology until it has an approved business case from the Ministry of Health. Prior to primary HPV screening in Ontario, cervical cancer screening is recommended to start at the age of 21 with cytology every 3 years. So in summary, for cervical cancer screening in Canada, what we have is no routine access to HPV as part of cervical cancer screening. We have several important studies going on. Most provinces use liquid-based cytology, but I would say it's fair to note that we have one province that has been very clear about its recommendations for primary HPV screening, and other provinces moving towards that, as well as hopefully some national guidelines that maybe give some clarity on that. But I think we've chatted a bit about some of the governance and leadership, some of the elements of providers that need to all coalesce together to make movement towards a shift in screening. But one of the final things I'm going to just leave you to think about is that we also need to ensure that the women are engaged in any discussions about the acceptability of HPV screening. I've just finished a study with partners in the HPV focal and other colleagues, and we looked and asked women whether they would be willing to undergo HPV screening for routine cervical cancer testing. And interestingly, about 85% of women said, yep, I'd be interested, I would be willing to do that. However, when we advised them of the extended screening interval, the willingness to be screened for HPV for cervical cancer dropped to 54%. So some significant difference. And I'm giving an abstract on this later on this week, and I think what's interesting is to see the qualitative comments that the women make, and they, by and large, are around safety, the feeling that it's not safe, and the other issue is cost. They believe that that's being driven by cost, and so they express substantial concern that the extended interval has nothing to do with safety, but is driven only by the government's desire to actually save money. So when we think about provider and system changes, there's a lot of work to do as we move forward towards primary HPV screening. We need to be mindful that our providers, not only our clients need support and education, but our providers need support as well in terms of understanding both the benefits of HPV screening but the harms of over-screening. And we also need to capitalize on innovative opportunities for screening. Finally, we also need systems that help us to help the practitioners and the women make the best choices and adhere to recommendations for best practice. And with that, I'll end. Thanks very much.